I think it is about common problems in glaucoma, and we are lucky to have a stalwart amongst us from Egypt, and we will he is going to speak on advanced glaucoma management. So, Dr. Monem, can you please go ahead? So I'll request everybody to stick to their time because the session has to be handed over to the next speaker in time.
The Egyptian Ophthalmologic Society to thank the organizing committee for inviting me here. Today what I'm going to talk about is to talk about advanced glaucoma, what's the current management in practice, why this group is very important, because there's increased risk of morbidity and mortality in such a case as it affects a broad array of daily activities of the patient, and these patients are usually stigmatized, underemployed, or non-employed at all, with so many problems, including health and mental difficulties as well. The annual cost of glaucoma care in the United States of America, we can know here that the impact of such advanced glaucoma cases per patient is close to $2.5 thousand a year per patient, as compared to half to $1,500 a year. Most of the cost of glaucoma care and advanced glaucoma goes to the surgery in addition to the low vision aids. If we go to the epidemiology of such a disease, we could say that a significant portion of glaucoma patients present late in the advanced stage of glaucoma. In the United Kingdom, 38% of glaucoma patients are present in advanced stage, and 45% of glaucoma patients in South Africa are presented while at least one eye got blind from the disease. What should we know about the advanced glaucoma? We have to know the definition, how to diagnose and to follow up, what are the challenges, how to reach the target intraocular pressure in this patient, how to treat medically, surgically, or laser, and what kind of surgery are you going to offer for such a patient. Regarding the definition, we shouldn't stick to the Hodab, Bash, and Anderson perimetric glaucoma definition for advanced glaucoma, and we could define this patient as those with near total cupping of the optic nerve with or without severe visual field loss encroaching the central 10 degrees of fixation. Here is the Hodab, Bash, and Anderson criteria, which is representing the perimetric glaucoma only, and structural integrity is affected too much and earlier than the perimetric glaucoma. What are the risk factors in this patient? So many risk factors are there. One of them is the ocular, and the other one is the non-ocular risk factors. The most important ocular risk factor is the presentation of the disease while there is advanced structural damage, in addition to high or marked visit-to-visit fluctuation of the intraocular pressure, which contributes too much to the development of advancement of the disease. The most important risk factor also for the advanced glaucoma is the low socioeconomic status and poor compliance of the patient. How are we going to detect the progression in such a patient? So many aspects should be addressed in this patient with late disease, from the patient's symptoms, identifying any secondary cause and take care of it, and the monitoring the structure and the function, in addition to visual field, using of the devices, and long-term follow-up, which should be employed 3 to 4 monthly, or as early as deemed necessary in such a kind of patient. If we go to the patient's symptom, we should address this and listen carefully to the patient that he is unable to see part of the words as he used to see earlier, booming into things more often than previously, transient visual loss and visual hallucination. If we go to the structural damage, we should say that this change in the structural damage is so subtle to be detected even with the most advanced machines that we see now. And most of them is transient, like the disc hemorrhage. So we should document and see this disease. If we look to this patient who progressed in different stages of advanced disease and look to the cup disc ratio, we could say that it's nearly the same, despite the fact that the zone beta peripapillary atrophy has increased, as you could see here, in the same patient. Some people might say that the spectral domain OCT could detect these changes. We could say no, it is not possible. If you look to this graph, we could see that the spectral domain OCT in this patient looks closely similar to each other. If you go to the visual field, you could see that the right one is more advanced in the functional damage than the other one. So the imaging device and the structural damage is not possible to follow such a kind of patient with this imaging modality. The other could claim that the new ganglion cell assessment could be a possible option. We could say no, because the disease progression didn't follow a linear aspect, but it is rather exponential. Early in glaucoma, there is a broad and long-term loss in the ganglion cells. If we compare it to late stage, it is very narrow here in advanced glaucoma. The visual field change in this patient is the most important aspect to be addressed in addition to the symptomatology, and it might be the only possible way to follow the patient with. We should resort to examining central 10 degrees using size 5 instead of size 3, and examining the cardinal points around fixation and the quadrant total sensitivity as well. If we have to look at this graph, central visual field 42 dash, we could say that it examined only 12 points in the central 10 degrees with 6 degrees apart, as compared to 68 points with 2 degrees apart distance in the central 10 degrees visual field. And in the central 24-2, you couldn't see any defect here. If you examine it with the program central 10 degrees, you could see that there is a scotoma, central scotoma here, which could be detected. So we should do central 10 degrees for every patient with advanced glaucoma. As you could see here also in this exam, this is the point that is examined, and no defect is detected superiorly. If we examine in details with the central 10 degrees, we could see that we have a defect like central defect, as you could see here. And sometimes if we examine the ordinary visual field, you see that the picture is black and no much details to see. If you resort to central 10 degrees, you will see more details, as you could see in this one. Sometimes, if you examine the patient with Goldman size 3, it is totally black and disappointing both for the patient and doctor as well. If you examine with the size 5 target, you could see more details and be able to follow up in the future. Also, if we didn't follow up with these cases, we could follow up with the quadrant total sensitivity and to compare it in the next visits, or to go to point-wise comparison for each point by itself. What is the challenge in advanced glaucoma? The main challenge here is that we have to avoid loss of the remaining portion of vision in addition to maximally control the intraocular pressure. How we get this? Through lower intraocular pressure, target intraocular pressure, gradual decrease in the intraocular pressure post-operatively, in addition to avoid the high post-operative complication. That should be avoided. The patient, such a patient is anxious and fear from surgery, and the doctor as well feels that he is in a difficult position managing such a patient, that he might got blind after surgery. That's why we should lower the intraocular pressure to the lower teens or the single upper digit, and to reduce the intraocular pressure fluctuation. Both of these factors has the strongest evidence in protecting the optic nerve and the remaining visual field as well. What is the management strategy in such a patient? So many aspects to be addressed. Biosociospiritual aspect of the patient should be addressed. Aggressive lowering of the intraocular pressure should be employed. This is an aggressive disease, and there's a battle between the aggressiveness of the disease and your steps that should be steady and fast. Medical therapy could be employed in some cases. Laser has some rules. Surgical treatment, what is the surgery that you are going to do? Trabeculectomy, or we should resort to a minimally invasive surgery, or go to the glaucoma drainage devices. The mechanism of glaucoma, general health status, age and life expectancy, psychological aspects, socioeconomic status, patient caregiver and partner should be counseled well, and instructed how to help this patient. The aggressive lowering of the intraocular pressure is the only proven treatment in preserving the visual function in advanced disease. Fluctuation should be considered if we have progression of glaucoma despite the lower intraocular pressure measurement during each visit. Medical therapy has some rule, but not much. But with this condition, if the patient is progressing slowly and might not be expected to live long to get blind during his life, and he can afford treatment in addition to the presence of the disease. How we can use prostaglandins, beta blockers, and so on. Laser trabeculoplasty, selective laser trabeculoplasty has no rule. Micropulse and transscleral cyclophotocoagulation could be used. Surgical treatment, primary glaucoma is the trabeculectomy is the most important. Just 1 minute, I will finish. Of course, wipe-out phenomenon could occur in this patient. Primary trabeculectomy should be offered for each glaucoma with advanced disease with technical modification, especially if we have, like, okay, sorry. The videos.
Okay, thank you, Dr. Monem. I think we are run out of time.
Okay, thank you.
So we will love you to be here around with us, so that we can keep asking you
Thank
how
you.
our management is different from yours in Egypt. So please join us on the dais.
Thank you.
And thank you very much for a wonderful talk. And we'll now go on to Dr. Prateep Vyas. And what we want Dr. Prateep to clarify for us is that, and it is very common that you'll get a patient who has got normal pressures, whatever you do, but the fields and disc are like totally glaucomatous damage. So what is to be done over there? Dr. Prateep, kindly enlighten us. Mic, please. Yeah, okay. नहीं, उस तरफ है.
Good morning, friends. Thanks, Dr. Harsh, for having given me this opportunity. You know, the topic given to me is, it's working. The IOP is in low teens, but the disc and fields have a glaucomatous damage. If I ask the same question to all of you, I'm sure that 99% of you would say that yes, we have to treat these patients. And why not? If you have a patient like this, where the intraocular pressure you have measured is 14 millimeter of mercury, but this kind of a disc where you can see the inferior notch, splinter hemorrhage, and correlating visual field changes, then who says that we should not treat this patient? Yes, obviously this patient deserves a treatment and we must treat the patient. But the topic is given with some specific reason. There might be some conditions where you may not like to treat the patient. Look at what are the conditions where you can have normal intraocular pressure but abnormal disc and abnormal visual field. It could be an intermittent angle closure glaucoma. When the patients come to you, you record a normal intraocular pressure, but intermittent rise in the intraocular pressure might have caused some damage to the disc and reflecting on the visual field. Very thin cornea, fluctuating IOP. The patient has presented to you at the trough of his IOP. Steroid induced. Long before, at the childhood, might have taken lots of steroid for the vernal catarrh or maybe some other disease, and now patient might have discontinued the steroid, and that steroid-induced glaucoma might have caused the defect, but now the pressure is normal. Old trauma, acute elevation of IOP because of hyphema and trabeculitis might have caused some damage to the optic nerve and reflecting the changes on the visual field. The senile sclerotic disc, most of you are familiar with that. Recurrent uveitis like Fuchs and PS syndrome, Postner-Schlossman syndrome. Some neurological condition Most important is the congenital anomalies and ischemic optic neuropathy. Patient has undergone bypass surgery. The blood pressure has gone down significantly and has developed the damage. If you have these kinds of discs, then obviously they will have some visual field defect, but it will not correlate with the intraocular pressure, and these patients may not have the glaucoma. I will take you to the journey of a couple of my patients. This is one of the patients, who has reported to me with these kinds of discs and the normal pressure. The pressure was 14-15 millimeter of mercury in the right and the left eye, and you can see that the right eye disc is pretty healthy, and in the left eye there was a slight inferior notch and the vertical cup has enlarged. I did the perimetry for the patient and the Anderson criteria was not fulfilled. So obviously the GST was within normal limit in both the eyes, so I decided not to treat the patient. The same patient has reported to me after a few years, and there was an inferior notch, RNFL defect, and a classical glaucomatous defect, what we see in the normal tension glaucoma, which is approaching the central part. So this patient, because I did not treat the patients at the right time, I did not intervene, so the patient has progressed and developed the scotoma, and this scotoma would remain lifelong. So that is the disadvantage when you decide not to treat just on the basis of the disc changes and the visual field and the perimeter and the intraocular pressure. I will take you to another patient. Look at the disc. Looks very much glaucomatous, but the pressure is normal. I did the perimetry and the Anderson criteria is fulfilled. In both the eyes, there is a superior arcuate scotoma. Did the OCT, it is correlating. So definitely I put the patients on a treatment, but this patient intraocular pressure never went up more than 14 millimeter of mercury, even on phasing or DVT or diurnal variation. So I withdrew the drug, and believe me, I did the 15-year follow-up for this patient, and without treatment, he has not progressed yet. So this patient does not have a glaucoma, though initially I decided to treat, and in the previous patient, though initially I decided not to treat, but the patient has progressed. This is the case where, one of my fellow was very happy and came to me, sir, pressure is normal, but the disc is showing some changes. And when I did the perimetry, then there is a correlating superior arcuate scotoma. So I dilated the patient because I felt that the disc is normal, and that is the reason that why the patient had a superior arcuate scotoma. Believe me, this patient has undergone trabeculectomy at the age of 7 years. And I have done the 15-year follow-up, and all of you are fully aware that it's a colobomatous disc that has caused the correlating visual field changes. So sometime you see the disc pellar and you feel that patient might have a normal tension glaucoma, and it's a very shallow cup, which is a typical of a normal tension glaucoma, but when you do the perimetry, then you get the neurological field defect where the vertical meridian is respected and the patient has a pituitary tumor. Similarly, the AION, you feel that the patient has a disc pellar and a very shallow cup and inferior altitudinal defect, where in many of your normal tension advanced glaucoma patient, you would see that the scotoma has reached up to the horizontal meridian. So let us talk a couple of things about the normal tension glaucoma, because what my topic is basically for normal tension glaucoma. So this is a classical normal tension glaucoma, a shallow cup, more pellar, parapapillary atrophy, you can see over here, and the splinter hemorrhage and the correlating visual field changes. So this is a normal tension glaucoma, and this is the patient where you must treat the patients. What are the cardinal signs of the normal tension glaucoma? The disc hemorrhage, the parapapillary atrophy, and the correlating visual field changes. And in these patients, Initially, the defect is more central and then it spread and cover the one hemifield or both hemifields. So, if you study more in detail about the normal tension glaucoma, then there are so many vascular causes, because you always debate that why these patients, they have a low intraocular pressure. So the migraine could be one, the Raynaud's disease, the low nocturnal blood pressure. It causes a less perfusion to the retina. And the CFS pressure is low in many of these patients. It's a new concept because there is a pressure gradient, the intraocular pressure is high and the CFS pressure is low, so there is more pressure on the lamina cribrosa and it causes a damage, the visual field defect. The sleep apnea, most of us are aware of this. The thin cornea, all of us are aware of this. All these normal tension glaucoma are the slow progressor, and the collaborative normal tension glaucoma study suggests that you should treat this patient and the target should be to reduce the intraocular pressure by almost 30% from the baseline. To whom to observe, to whom not to treat? Whenever there is a congenital anomalies, whenever there is a large disc and a large club, burnt out glaucoma, obviously they don't need any treatment because the pressure is already under control. Old uveitis, old steroid abuse or use, and the old trauma which has caused the damage, and now there is only one quadrant recession, so pressure is under control. Whom to observe? Okay, so let us talk about the treatment part of the normal tension glaucoma. The PG analog is drug of choice. Some people prefer the alpha-2 agonist and the carbonic anhydrase inhibitor because they feel that they might be the vasoprotector or the neuroprotector. Beta blocker should be preferably avoided. And about the follow-up should be similarly to the patient of a primary open-angle glaucoma. So in summary, the normal tension glaucoma is a separate entity and it should be investigated thoroughly even for the systemic cause. And the lowering of the IOP is required if the patient has a normal tension glaucoma, and it should be 30% from the baseline, and surgery should be considered for those patients who are the fast progressor or where you are not able to achieve the target intraocular pressure. Thank you very much for your patience hearing.
I think very wonderful, but it's absolutely perfect. I don't think that we could have done a better job. Anybody could have done a better job on that. And is there any question for Dr. Pradeep? Anybody who feels that the normal tension glaucoma should be taken up in any different fashion? Because very, very nicely dealt that it is exactly a diagnosis of exclusion. So first you be sure that the first slide he showed, that it is not something else like intermittent ACG or something like a steroid-induced glaucoma which has now died down, or it is the anomaly of the disc. So these things you have to rule out. Once you have ruled that out, whatever the pressure, you have to bring it lower than what it is. Dr. Monam, would you deal in any different way?
Normal pressure glaucoma for sure is a specific entity and it's so much common. 20 to 30% of cases are presented with normal pressure glaucoma. Systemic causes are implicated so much, and also we should resort to do some water drinking tests because some cases are not really a normal pressure glaucoma, but it have a spikes with fluctuation with the intraocular pressure. And we should look also to the pattern of using the antihypertensives, specifically those who are using antihypertensive at night with decrease in the mean arterial pressure during sleep. This is very important.
Excellent. So we should do a 24-hour BP recording, check there's nothing going wrong there. And very, very rightly said about that part. Sunita, you want to add something?
I think as has rightly been mentioned, that's a diagnosis of exclusion, but I would say that we should differentiate it from non-glaucomatous causes. He has already explained.
Beautiful.
And I have seen, one or two patients wherein the glaucoma has progressed very fast in one eye. So if it's a unilateral asymmetric glaucoma, then maybe imaging is very, very important to rule out any compressive, neuropathies. So, one short. So I think that is very true.
So I think that was very well done. And let's move on. And we have Major General Sagrika Patyal, and we always tell her we are grateful to you for the service to the nation as an army person.
Thank you, sir.
And she will be speaking moderately elevated pressure with normal fields and disc, treat or not. So it is the totally opposite dimension to what Prateep took. Here we are on the other side. So please go ahead, Sagrika.
Thank you, Dr. Harsh, for giving me this opportunity to speak. So now we have normal pressure, and now we go on to pressures which are elevated, but everything else is normal. So at the very outset, I'd like to tell you that I would like to treat. And why I would like to treat is because of the slides that in my slides, I will explain why. So what is ocular hypertension? As we know, it is consistently elevated intraocular pressure greater than 21 millimeter mercury above the and by Goldman's applanation tonometry. And this is a very important fact that must be underscored all the time. On 2 or more occasions, one pressure reading makes no sense. Don't do it by NCT, please do it by the Goldman's applanation tonometry. In the absence of any clinical evidence, that means you have seen the patient thoroughly, which is something that we keep on and on talking about, of any kind of optic nerve damage, visual field defect, or any other pathology which could possibly explain the high intraocular pressure. Why is it so important to study ocular hypertension? Because we have found that ocular hypertension is the most important risk factor in the development of primary open-angle glaucoma. Now, there's a huge amount of debate about ocular hypertension. Shall we rename it? Ocular hypertension should be treated, should be not treated? If suppose we treat it, then what are the side effects of the AGMs? Shall we treat it with lowering drugs or with surgery? Shall we wait for glaucomatous damage and then we treat it? And what will happen if suppose there's visual loss? Then we are going to definitely feel very bad and the patient is going to suffer all his life. So has this debate really reached a conclusion? This conclusion has primarily been reached by lots of studies, primary one being the ocular hypertension studies, which was done on a large 1,636 patients, where it studied the age cup disc ratio. This is very, very important. The intraocular pressure, they discovered that these are the predictive factors for the development of primary open-angle glaucoma in individuals with ocular hypertension. This was the first study to prospectively document that if a person has a thinner cornea, then in that case, this predicts the development of POAG. Now, combining all these factors, it identifies patients who are at moderate to high risk for developing glaucoma. What we have to understand that we have to take all these factors into consideration when we are looking at our patients and try to understand that OAT study is going to give us this benefit. These patients will probably benefit from being given medical treatment. It also suggests that patients to get treatment of patients with higher IOP more than 24 millimeter of mercury, amongst those who have a greater than 2%, they have a greater than 2% annual risk of developing glaucoma, and this is cost effective. So if we look at the Indian scenario, we have already found that there are ocular hypertensive patients done by the Chennai group study, and they have found 62 out of 2,852 subjects, men being more common and incidence being higher in the rural cohort than the urban cohort. They all were found to have a higher baseline intraocular pressure, and increasing age, they found it to be significantly associated risk factors to development of ocular hypertension. But what about the development of ocular hypertension to glaucoma? Older age, significantly higher intraocular pressure, large vertical or horizontal cup disc ratio, greater SAP on greater pattern standard deviation on standard automated perimetry, greater thinner CCT. Other risk factors are age, race, positive family history must never be forgotten, in which siblings is very, very important, low diastolic perfusion pressure, which has already been talked about by Professor Vyas. Now, what about the conversion of ocular hypertension to glaucoma? Population-based studies tell us that approximately 9.5 to 17.4 patients of ocular hypertension develop POAG without treatment over 5 years. Around 1.5 to 10 of these untreated eyes stand risk of going blind. So will you not treat them? 100% you'll treat them. Even after treatment, 4.54% of the OHD eyes will develop glaucoma, and of them 0.23 to 2.4% eyes still stand the risk of going blind. So it also, remember, it has not just an impact on blindness, huge socioeconomic impact with potential to debilitate the quality of life of diagnosed persons once the disease starts progressing. What are the medications that can be used? You can use beta-adrenergic antagonists, topical carbonic anhydrases, then inhibitors, the prostaglandin analogs, and of course the alpha-adrenergic agonists. We can do follow-up and diagnosis of patients of ocular hypertension by doing a very good SAP, that is standard automatic perimetry, a good ophthalmic examination of the optic disc, and other tests also which have been earlier tried but really not stood the test of time. There's a risk calculator also which is available, which can be used. We used to use it earlier, but I don't think many people use it now. Now, let's talk about a couple of cases. A 53-year-old male with no comorbidities, no family history of glaucoma, no steroid use, found to have pressure of 36 and 37 in 2009. Now, in 2023, this is the last time when he has come to me, probably will continue on medication and follow-up. 2018, everything was normal. His diurnal control, because he was on medication, was normal between 18 to 20, and CCT was normal. At this time, we have to determine what is the target pressure. When everything else is normal, your target can be approximately 18 to 20. I think that's perfectly fine. He was on AGM, anti-glaucoma medication, Zalacom and Dorzox in the right eye and Zalacom in the left eye. Mind you, he'd been treated from 2007. Various ophthalmologists have been giving him various medication. 2018, his fields were normal. These were his optic nerve heads. And again, you look at the OCTs, but you realize one thing, that his optic discs were slightly on the smaller side. This is very important to understand. Therefore, we will definitely treat such a patient. In 2022, when he came, his fields were normal and his optic discs remained the same. His OCT is absolutely the same. Last follow-up was done in 2023. Fields were done. We did not do the OCTs. We just did the fields, and no change was detected. So the questions that we must always ask ourselves, what if the patient who's on such treatment is going to develop ocular surface problems and other side effects? Mind you, these are the concerns of the patient and of the doctor. Should he actually have been treated? But we know, yes, there's a high prevalence of ocular hypertension, and low conversion to rate to POHE. So these are questions that keep on troubling us. Should he have just been kept on follow-up? Should the number of AGMs have been decreased? Because these are things that occurred to me. Because we have got to consider what is the cost of treatment to the patient. How long should we keep on treating? What should our target intraocular pressure be? Should we contemplate surgery for such a patient? Mind you, in newly diagnosed OHD and POHD patients, it may be a viable first option in those with poor compliance, not able to come to hospital, intolerant to medication. We might have to think even of surgery. What about cataract surgery in such patients for control of intraocular pressure? We know that cataract surgery also controls pressure. Mind you, good treatment for visually significant cataract and OHD, yes, it may be an option. Now, there has been a study which has been done by the National Institute of Health and Care Excellence, where they found that primary selective laser trabeculoplasty is a very cost-effective alternative to ocular hypertensive drugs. One go, one treatment, and probably finish off. Now, I come to another case which has been with me from the army. 2006, 46-year-old male, glaucoma suspected because of large CD ratios, normal fields, pressures normal, strong family history because his father had glaucoma, vision was normal, gonioscopy was normal. His pressures were mildly raised in the left eye, and his CCT, mind you, was slightly on the higher side. His fields were normal in 2006. He was kept on follow-up. Now, based upon, as usual in the army, you keep getting transferred, so you get under many other ophthalmologists. So this gentleman, the ophthalmologist, must have decided that this is a field defect, and so he started the patient, and mind you, he took the pressures also, his blood pressure also was recorded, and he was started on AGMs. So now in 2016, he reverted back to us, no field defects in both the eyes. 2019, no field defects, both the eyes. 2022, no field defects, both the eyes. Now comes the dilemma. The ophthalmologist changed, so medicine changed. Timolol became Travacom, and IOP was only 19 and 17, but taken on NCT. OCT was done annually, it was normal. He developed now PEDs also. So mind you, such a long treatment with the patient, he might develop some other features also, which you have to take into consideration. In 2013, the drug Dorzox was added, Dorzox T was added to Travatan. In 2018, he went to a larger institute, and where they found that everything was normal, and because he had developed the PDs, therefore they changed the drug Travatan to Combigan. So again, you have to think of all those things also in these patients who are on chronic follow-up. Now, in 2018, he underwent Lucentis, and the AGM was changed to Dorzox T and Alphagan. In 2022, he's come in 2023, which I have not added, but the patient is absolutely normal on the same medications, and in 2022 also everything was absolutely normal. So what are the lessons that we learn from such a patient? See, I have said at the very beginning that we must treat these patients. The first thing is that we have to examine the patient very thoroughly. The counseling of the patient is very important for follow-up. The patient has to come back to you. You have to again examine the patient, not by extensive tests, but at least by a thorough look at the optic nerve head, pressure recorded by AT, and also your fields. Change AGMs only when required, depending upon diurnal control, development of other ocular diseases. Be prepared for the unforeseen pressure or optic nerve head changes, and consider other options for treatment at that time. Thank you so much for a patient hearing.
I think that was very nicely dealt, and I think it's very, very clear to now us what is happening. So ocular hypertension, the pressures are high, the rest appears to be normal, and that is one place where I think OCT really plays a part, that it can detect the earliest of the changes. So if there are no changes whatsoever, if the pressures are ever above 27 to 28, I think irrespective of anything else, we treat. But if they are somewhere 24, 25, 26, then one has to see the associated factors, whether there is any family history. There are other factors which are tricky. The fields are looking a little plus minus. The disc you are not sure of. You do a diurnal, you have to do a diurnal variation. What is the corneal thickness, if it is on the thinner side? So all these factors would then decide, and you talk to the patients. Because like Madam rightly said, you treat and you'll have side effects of the treatment. Plus mentally he's disturbed that, okay, I've got a disease. So plus the social factors, plus the cost. In India, the cost is definitely an important factor that we can't neglect. So then you have to decide all these and then take into account. Another interesting thing that my teacher used to teach me was that, say if the pressure is 26, you give a drug, the pressure comes down to 23, 24. That means probably for that eye, that pressure was the normal pressure. But you treat an eye with 26 with a single drug and the pressure comes down to 18. That tells you that the eye was probably diseased. So this is a trick that is not written in any of the books, but I think this is something for you to remember. Thank you very much, Sagarika.
I think that's great information, the last one that you gave, yeah. Thank you.
So we now go on to Sunita, and Sunita is one of the pioneers in MIGS in India, and she is with Shroff Charitable Eye Hospital heading the glaucoma unit and number of administrative posts. So she'll tell us one of the most difficult things. If I go to any international meeting, the only session I want to attend is how to make sure that this myope is a glaucomatous or it is not a glaucomatous eye. Always we are confused. So Sunita will clarify for us what to do.
I hope I will be able to clarify that. So thank you, Dr. Harsh. So my topic is, in this myope, am I dealing with glaucoma or it's only myopic changes? How can I ensure? So as we know, the association between glaucoma and myopia has long been recognized. So while the two conditions coexist, there is often a diagnostic challenge. So why myopic discs are more predisposed to glaucoma? Because there is stretching and thinning of the lamina cribrosa, which leads to decreased distance between the retrobulbar CSF space and the IOP compartment, resulting in steeper pressure gradient across the lamina cribrosa, which is the primary site of damage, therefore causing more predisposition to glaucoma. It's difficult to detect glaucoma in myopic eyes because the disc evaluation is more challenging because of the morphological changes in the disc. There is uneven expansion of the posterior globe, as you can see here, with tilted disc and associated parapapillary changes. Degenerative changes in the myopia, as you can see, can cause visual field defects which can mimic those seen in glaucoma. Also, progressive myopia, as the myopia also progresses with the passage of time, it can lead to progressive tilting of the disc and difficulty in detecting progression of glaucoma on structural as well as functional assessment. And most importantly, IOP estimation may be inaccurate because of the thinning of cornea and lower corneal hysteresis. So the morphological diversity of the myopia includes tilting and cyclotorsion, myopic conus, parapapillary atrophy, large discs and large cups, which can mimic glaucoma, of course, and NRR may not be interpreted clearly due to shallow cupping and tilted disc. So tilted and torted discs are very common in myopes, almost 40 to 66% in young myope population. So in tilted disc, we often see these D-shaped optic nerve head with one hemisphere of the disc more elevated than the contralateral half. And if the disc is rotated more than 15 degrees from the sagittal axis, then it is said to be torted. As you can see, sometimes you get this 180 degrees of torsion, and here it is very difficult to interpret the disc. We already know about the alpha zone and the beta zone. Beta zone is more commonly seen in glaucoma associated with myopia. But now with the latest technologies, the HD OCT, now we are able to see even more zones like gamma zone and delta zone. So gamma zone is the scleral flange which is present between the disc and the beta zone, and here there is no Brooks membrane, and delta zone is a part of gamma zone with no blood vessels. So these you can identify on OCT. So this is the normal disc, this is glaucomatous disc with alpha and beta zone, this is myopic disc with alpha, beta, gamma zone, and gradually you will see as the glaucoma and as the myopia advances, you will see more degeneration in the retina. Now coming to visual field analysis. So why it is difficult to interpret? Because myopic retinopathy can obscure the glaucomatous defects. However, one tip here is that since the myopia involves parapapillary region, so most of the defects you will see is around the blind spot here. So that the damage will not start in the nasal side, which is more common in glaucoma, because the nasal steps then progress to the arcuate area. But here you will see this area is clear, but here you will see the defects in the blind spot area, which are going in the superior quadrant, and this is because of the parapapillary atrophy. Sometimes the central fixation is also involved because of the macular changes. And as we know, glaucomatous defects occur initially in the germs area, this nasal step, and going into the arcuate area. So I think this is a differentiating point which one should remember. And if the visual fields are progressing despite stable macula or myopia, then that may also indicate glaucomatous progression. OCT has no value, especially in high myopia. I am just showing some pictures to show that most of the times it is fallacious. And one of the important reasons is that the volume scans which are acquired with OCT has a depth of 2 millimeter. But the axial length is so high in most of the high myopes that the image is not being captured in one section, and this leads to segmentation error. Secondly, there is no normative database available for myopic population. So these are the segmentation errors, and you can see this temporal shift of blood vessels and temporal displacement of RNFL leading to these nasal defects in high myopic patient. So these are another segmentation errors, another errors in myopic patients. Again, temporal shift of RNFL bundles here leading to segmentation error. So these are some of the cases. This was 22-year-old male presented to us, and he had high axial length. The IOP was normal, vision was good, and you can see tilted and torted disc. And since this disc is slightly larger, you see a larger cup. OCT, of course, has a lot of segmentation error. It was not properly captured, so you don't rely on OCT. But when you look at the fields, field is more